And the topic for today's discussion is, what do we do with the diseased organ donors infected with tropical infections? I bring along with me the best wishes from all the faculty and students of the historic Madras Medical College. Straight away, let me go into the dengue. For the past 1 decade or so, most part of India, there have been, every year we used to get kind of epidemic of dengue, which has not been there 2-3 decades ago. So the point of concern is that dengue can be transmitted through the graft. And donor screening is preferable during periods of high disease activity in the region using NS1 antigen. Actually, there is a debate whether universally all the donors are to be screened, but the current view is that the countries are certain parts of the country where the high endemicity or the recent outbreaks of dengue, it is preferable even if the donor is asymptomatic to screen for that. And donors with dengue positivity, please defer donation at least for 30 days. This is about the living donors. And the deceased donors with history of dengue within 30 days defer organ retrieval. Why do I say so? This is a publication from Delhi, Dr. Shyam Bansal's group. During a particular dengue outbreak in 2021, there were 900 patients with the dengue admitted in Delhi hospital, out of whom 23 were kidney transplant recipients, of whom 4 were in the immediate post-transplant period. Probably these patients were in the incubation period at the time of transplant. What happened to them? The mean duration of hospitalization increased from 8 days to 15 days, and one of the patients even required ICU care, and 2 of them had graft dysfunction. So dengue in the post-transplant period is really troublesome. It may not be prudent to go ahead. Yet another nice paper from Kidney International Reports published recently. I happen to be the reviewer for this paper as well. Very interesting paper in the sense that, as you can see here in the top panel, it depicts the data of 2 recipients from the same donor. The lower panel, the 2 recipients from the another donor. All the 4 patients had immediate post-transplant period dengue. So the importance of this paper is that allograft as the source for dengue has proved by genomic analysis of dengue virus in the donor and recipient. They developed dengue, the recipients developed dengue, and the researchers, the investigators went back and looked for presence of the dengue serology in the donor, and it was positive, and the genomic analysis confirmed that it is the same dengue virus. Another important point I would like to highlight is that it is not a very easy clinical course. See, as you can see here, this is the duration of dengue viruria in the patients. It is a wide range of duration of dengue viruria, 18 days in patient 3, up to about 385 days in the patient 2. So even after the resolution of the clinical phenomena and the serology and other things, there can be asymptomatic dengue viruria in transplant recipients. Another point to note is that after a gap, when the lymphocyte count dipped in the recipient, again there was a reappearance of dengue viruria. What does it mean? That in some of the patients with kidney transplant recipient or other organ transplant recipients, probably the dengue virus does not get completely eradicated. It can come to surface again and again whenever there is a situation conducive for it. Fine. So there are classical clinical presentations of dengue. The 2 most troublesome presentations are dengue hemorrhagic fever and dengue shock syndrome, and of course macrophage activation syndrome. But because of the immunosuppression, there can be atypical presentations of dengue in the transplant recipients, and the diminished T cell response leads to atypical presentation. And because of the being on immunosuppression, there can be a very slow viral clearance resulting in adverse outcomes. So this is about dengue. A word about chikungunya. Fortunately, for the past couple of years, at least Tamil Nadu, there was no great epidemic. A few years ago we had it. If the donor is found with chikungunya, please defer donation for at least 30 days. How about malaria? Again, malaria incidence is coming down, at least in our state. The donors and the prospective recipients should be deferred transplant for 3 months after treatment of malaria. Should be screened for malaria in all the donors. It is not so. Screening only in symptomatic febrile recipients and donors. And how do you do screening? The thick smear, peripheral smear using GIMSA stain, and real-time PCR is more sensitive, but it is not available in most part of the country. How about leptospirosis? It again, There are certain parts of the state leptospirosis plays a havoc, particularly in the months of October, November, and December. Fortunately, again, the incidence of leptospirosis is coming down. It's a spirochetal disease. It varied clinical presentation, starting from relatively milder forms up to multi-organ dysfunction syndrome can happen. It is diagnosed with the serological test, microscopic agglutination test, and of course, IgM ELISA. Organ retrieval has to be deferred for 3 months, at least 3 months after recovery from infection. This is the current consensus. Fine. Strongyloids rectoralis, it has been identified as an emerging infection in the solid organ transplant recipients. Wide range of clinical presentations starting from asymptomatic chronic carrier state up to the disseminated disease. The two important clinical syndromes we are really worried about with strongyloids is the hyperinfection syndrome characterized by hemoptysis, respiratory distress, and GI bleed and so on with 50% mortality, and the disseminated disease with 70% mortality. Donor-derived strongyloids infection in solid organ transplants is a feasibility, definite feasibility, and it has got a very unfavorable outcome. So what do we do? In certain areas where the strongyloids rectoralis incidence is high, like Southeast Asia, and Latin America, and so on, it is prudent to screen the recipients as well as the donors with simple stool examination, but of course it has got limited sensitivity up to 30% only, whereas ELISA IgG is preferable, which has a sensitivity of as high as 90%. And what do we do? I mean, it does not differ donation, but it requires treatment. You know, the infected donors and recipients to be treated pre-transplant itself in a living related donor transplant, whereas in the diseased donor transplant, start the treatment at the earliest in the recipient. How do we treat? Ivermectin is the drug of choice, 200 microgram per kg for 2 days, to be repeated after 2 weeks. The alternative is albendazole. Fine. Now, I'll just finish my talk with a case recent experience in our unit in Madras Medical College. Young male, 26 years, basic disease, vesico-urethral reflux with reflux nephropathy, was identified with kidney failure at the time of diagnosis itself as contracted kidneys. After a year, he became dialysis dependent. He was on dialysis. After a dialysis vintage of 6 years, he received a diseased donor transplant in January this year. ATG induction followed by triple immunosuppression and double ureter, so 2 DJ stents were placed. The intraoperative finding, there were right iliac nodes, biopsy was taken. So this is the donor data. The donor, who was the donor? An alcohol abuser and a seizure disorder on phenytoin. He was found unconscious, lying, and brought to hospital, found to have brainstem dysfunction. So it was recorded as a self-fall based on the kind of information given by the near and dear. He had leukopenia, 2,100 cells, and mild reduction in the platelet count. This was the initial donor data. We went ahead with the kidney transplant. There was a delayed graft function, required 4 sessions of hemodialysis. The last dialysis was on day 9. And the iliac node biopsy came as the reactive follicular hyperplasia with sinus histiocytosis. Nothing need to be done for that. He was on tacrolimus and mycophenolate and mofetil. Everything went on very well, as you can see here. And of course, he was pre-transplant itself. His hemoglobin was 7. Anemia was there. It was gradually, it was stabilized. And everything was fine. Initially, there was mild thrombocytopenia that also improved. After day 10, urine output crossed 1 liter. Everything was, we were happy about it, and the problem started on day 12. He started developing very high grade fever, continuous chills and rigors, no localizing signs whatsoever. Started on injection, carbapenem compound, because already was on piperacillin tazobactam, that was stopped, and we just took again a fresh set of cultures and then started on this. On day 15, fever continued. He developed leukopenia, so MMF and co-trimoxazole withheld. And in our center, sometimes we do come across fungal infection in diseased donor transplant recipients. So we thought, empirically amphotericin B started, and ultrasound didn't reveal any perigraft collection, and transplant Doppler was normal. Echo didn't reveal vegetations, and all the cultures didn't grow anything. We did COVID, SWAP, and H1N1, RT-PCR, everything was negative. So this is the picture. There was a progressive drop in total count, progressive drop in platelet count, hemoglobin was low, CRP started rising. Fever continued unabated, NS one antigen for dengue, IgM dengue, negative. Peripheral smear didn't reveal malaria. EBV, CMV, even though CMV doesn't happen in the first month, we did everything, parvovirus, everything was negative. And the markers for the fungal infection 1,3 beta D glucan and serum galactomannan assay were negative. Serum ferritin kept on rising. On day 22, 10 days, day 12, a fever started. On day 10, 10 days after starting fever, there was a further dip in the total WBC count and thrombocytopenia worsened. And this time he started developing loose stools, so all antibiotics were withheld and DJ stent removal was done. And sometimes, very rarely we have picked up tuberculosis by bone marrow studies in transplant recipients. So we were just clueless as to what's happening. Even we did in bone marrow analysis. That was not really contributed, that didn't reveal anything. On day 24, persistent fever, leukopenia continued and thrombocytopenia further worsened. And this time ID consultant said, it can be some bug which is not picked up in your culture, and why don't we start with ceftazidime, avibactam, subsequently aztreonam, and then ganciclovir, even though CMV is negative. Then to boost the counts, CSF, colony stimulating factor was given. Imaging studies revealed nothing. CRP started worsening. Serum ferritin kept on increasing. So whether we were dealing with macrophage activation syndrome, thinking that even IVIG was given. And there was a tremendous increase in the liver enzymes, It went up to 1,500 in addition to leukopenia and thrombocytopenia. So thinking that it could be a disseminated strongyloids infection, ivermectin was given. Then ivermectin was suggested by another ID consultant for its immunomodulatory action also. So we were just clueless as to what's happening. During the routine rounds, it occurred to me just like that. One more bug we have not looked for, which is very much included in the routine workup of any acute febrile illness in the recent past. Why don't we just do that as well? Even though we never thought that it is possible, because the patient is with us for about 30 days. That is, we looked for presence of scrub typhus, and that was positive. Initially, we were pretty skeptical about this. How come he developed scrub typhus? Scrub typhus already is with us for about a month or so, but this IgM, ELISA, has got 90% specificity, if not 100%, at least 90%. So nothing lost in starting. Doxycycline, we didn't want to waste time, so straight away we went for parenteral doxycycline, 100 milligram IVBD. You should believe what I say, the fever literally lysed within 48 hours. After 48 hours, and there was a gradual, very rapid increase in, improvement in all parameters, including platelet count and WBC count and so on. So we are almost certain that it is scrub typhus. We just wanted to know what happened to the recipient of the other kidney. The other kidney was in a corporate hospital. That gentleman got discharged with immediate graft function, but came back to the hospital on day 17 with a high-grade fever, leukopenia and thrombocytopenia. A red herring was here, the COVID was also positive. So the team went ahead treating as COVID with remdesivir and so on. Patient developed macrophage activation syndrome. So fever continued, so the patient received ATT and IVIG, colistin, ceftazidime, whatnot. Subsequently underwent graft nephrectomy, and subsequently patient succumbed also. By the time, we were also not sure about the diagnosis, so we could not pass the information to them. The liver recipient was with us. The liver recipient also started developing fever on day 17 with the leukopenia and thrombocytopenia. COVID-19 was negative. In him, scrub was negative. He responded to meropenem and tigecycline. A point here is that whether the liver recipient also was possibly a scrub typhus, probably that responded to tigecycline. The management of scrub is a bit tricky in the sense that it responds to very few antibiotics. One is doxy, the other one is azithromycin, and of course the higher antibiotic like tigecycline. Does not respond to colistin, does not respond to carbapenems, does not respond to cephalosporins and so on. So if you miss the diagnosis, you miss the patient, right? Fine. So patient got discharged happily on day 40 with normal creat and good. So you know about scrub. Now the scrub, we have to be more and more sensitized about scrub typhus, but in the immediate post-transplant period as well. So there is varied presentations of scrub typhus. The SHAR, which is supposed to be the pathognomonic phenomenon of scrub typhus, present only in 50% of the patients. The incubation period is 6 to 21 days. IgM ELISA has got 90% specificity, but ideal will be PCR, but unfortunately it is not available in most part of the places. And why the liver recipient tested negative? Sometimes there can be false negative because of immunosuppression or low titers of antibody. Please be aware of this fact in the post-transplant setting. In the entire literature, at least from Asia, we were the one, our MMC center is the only center which has reported a scrub typhus meningitis few years ago, but not in this scenario, that is 4 years after kidney transplant. Fine. So then we searched literature extensively, almost a similar clinical scenario from Thailand, a deceased donor, 2 kidney transplant, 2 kidney recipients and 1 liver recipient. All of them developed scrub typhus and all of them were treated successfully with the doxycycline. What I would like to highlight is that in the immediate post-transplant period itself, in a tropical country like us, we need to be aware of the epidemiological profile of the infections currently prevalent in that region, and then we need to have diligent information about handling such situations. Thank you so much.